Hello friends, now we are going to start the topic Haematinics, and as we all know that Haematinics are the substances which are required for the formation of a blood, and it is also used for the treatment of anemia. And so in that sense there is certain substances which are needed for the formation of blood, and these are the iron, there is a vitamin B12, and there is a folic acid. So now after that there is anemia. As we are concerned that we know that there is a certain efficient amount of blood loss occur in that anemia condition. So blood loss occur, it might be the acute or it might be the chronic conditions. There might be the impaired red cell formations also. There's a two things in that sense. There is a deficiency of essential factors like the iron, vitamin B12, and folic acid, and as well as there is a second thing is the bone marrow depression. So in a bone marrow depression condition there is a hypoplastic anemias occur, so that the body is not capable of producing enough amount of new blood cells, and after that there is erythropoietin deficiencies, in which there is the the erythropoietin is a hormone which is released by the peritubular cells of the kidney. So if these hormones are not releasing in a proper amount, so they don't prompt the bone marrow to make a more amount of RBC. So their deficiency leads to RBC deficiency also, and there is a hemolytic anemia is also occur, in which there is a destruction of RBC as well. Now, as far as concerned about the distribution of iron in a body, iron is an essential body constituent, as we all know, and the total body iron is in adult is about between the 2.5 to 5 gram. It's just an average of 3.5 gram, and in a man there is a need of 50 mg per kg, and in a woman there is a need of 38 mg per kg. Now, as far as concerned about the distribution part of the iron in our body, so in hemoglobin there is a 66% of iron is utilized. In iron stored also as a ferritin and hemosiderin in a reticuloendothelial cells, there is a 25%, and in a myoglobin they are stored in a muscles, in a heart muscles like that, 7%, and there is a parenchymal iron and in an enzyme formation like cytochromes and peroxidase, they are stored as a 6%, and they are utilized as a in a 6% amount. Now after that we come to the iron. As a iron is stored as a ferric form with apoferritin. So iron have a Fe2 Fe3 plus charge, and they combine with the apoferritin to form a ferritin, and these ferritin are stored in the reticuloendothelial cell, in a spleen or in a bone marrow and in a liver, and after that they utilize also as a parenchymal iron in an enzyme formation like cytochrome, like peroxidase, and like catalase or xanthine oxidase, and some mitochondrial enzymes also utilize. After that there is a certain amount of daily requirement which the human being need for proper functioning of iron in our body, or proper amount of iron is needed to maintain the homeostasis conditions of a body. So as far as concerned about the adult male, there is a need of 0.5 to 1 mg. In a female there is a need of 1 to 2 mg. In an infant there is a need of 60 microgram per kg, and in a children there is a need of 25 microgram per kg. And in a pregnancy condition there is a need of 3 to 5 mg, because in a pregnancy condition there is a lot more amount of iron loss occur through the menstruation. So after that there is a certain things which is required, which is a essential component for enriching the iron content in our body. These are the dietary sources, as we know, and there is a rich dietary sources. We call it a liver, egg yolk, dry beans, dry fruits, and wheat germs and yeast. In a medium condition there is a meat, chicken and fish, and spinach and banana as an apple. And in a poor there is a milk product we use, and root vegetables we also use in that condition. Now as far as concerned, we are now come on the pharmacokinetics of iron. Iron absorption, factor affecting iron absorption, mucosal blockage, and their transport, utilization, storage, and excretion. Now, as far as concerned about the iron storage, uh, we as know that the average daily diet of our body is 10 to 20 mg of iron per day, and in that condition the mainly the iron is absorbed by the intestine in our body, and the dietary iron is present in a two form. Either it is found in it's found in as a form of hemi, or in a inorganic form. So absorption of hemi iron is always been better as compared to the inorganic iron, and so the hemi iron absorb 35% as compared to inorganic iron absorb 5%. There is a certain enzymes is regulated in this, which is a hemi carrier protein 1, which is HCP1, and there are two enzymes also regulate these absorption processes, which is the two separate iron transport in the intestinal mucosal cell functions to affect the iron absorption as well. Now the first is the at the luminal membrane, the divalent metal transporter 1 carry the ferrous iron into the mucosal cell, and this along there is a second, which is the iron released from the hemi is transported across the basolateral membrane by another iron transporter, which is the ferroprotein. So these are the mechanism. After that, there is a certain things which is what are the factors which facilitate the iron absorption in our body. So these are the acid in which there is it favors the dissolution of iron, and it favors the reduction of ferric iron so that they can easily absorb by the intestine. There is a reducing substances, which is we can call it ascorbic acid. These agent reduces the ferric iron also, and also it make the iron more in a form of absorbable complexes. And in a meat condition, by increasing the HCl secretion and providing a more amount of hemi iron, so that a more amount of iron is absorbed by the intestine. As far as concerned about the factor impeding the absorption, which are going to decrease the amount of absorption of iron, is the tea, coffee, and antacids. They decreases by making the iron insoluble and decreases their bioavailability or their effect as well. There is a certain thing which is a phosphate also, they also decreases. There is a phytates which is found in maize and wheat, they also decrease the absorption. Tetracycline, there is an interaction with iron also, so they decreases the bioavailability or absorption rate of irons. And certain foods materials also in the stomach also decreases the absorption as well. Now as far as concerned about the mucosal blockage, we know that the gut has the mechanism to prevent the entry of excess iron in the body, because there is a need to maintain the homeostasis conditions in the body. So when the iron reaching the mucosal cell, it either transported in the plasma, or it either oxidized to form a ferric form and complex with the apoferritin to form a ferritin, which is the ferritin. Generally it is stored in the mucosal layer in a reticuloendothelial also, and is lost when they are said, or when their life is ended, is get abolished. So a large percentage is absorbed during the iron deficiency, but in a simple condition when there is not need to be absorbed that much cases, in gross cases the mucosal blockage fails. So large percentage absorbed during the deficiencies also only, and not in normal conditions. As far as concerned about the transport and utilization, so we all know that on entering the plasma iron, there is a free iron is highly toxic. So after entering the plasma, it's immediately converted through the enzymatic reactions or things to the glycoprotein transferrin complex with the iron, make a complex with the glycoprotein transferrin, and after that iron is transported inside the erythropoietic cells through the attachment of transferrin to a specific membrane bound glycoprotein that function as a transferrin receptor, and this complex is engulfed by the receptor mediated endocytosis. There is an endocytosis occurs in that transferrin receptor, and so that the iron dissociate form the complex at the acidic pH of the intracellular vesicle, and the relaxed iron, which the relaxed iron is utilized for the hemoglobin synthesis and other purposes. These are the utilization of iron for the formation of RBC in our body, erythron in our body. After that, there is a storage. They usually store in the reticuloendothelial cell, in a liver, spleen, and bone marrow, and as well as it also stored in the hepatocytic condition, and as well as in a myocyte as a ferritin and hemosiderin also. After that, there is tensionally iron is converted. They tensionally highly conserved one way substances stored in there is a storage which is stored in reticuloendothelial cells of liver, spleen. You can note it down. And after that, there is excretions, which is a highly conserved substances. It is tensionally conserved by the body. Iron is tensionally conserved by the body, and daily excretion of iron is about 0.5 to 1 mg per day. Mainly as a exfoliated GI muscles, some RBCs and bile, and in a bile. There is a certain amount of excretion through GI mucosal cells. There is a certain by the RBC and in a bile, and there are certain is released by the desiccated skins also, and there is a certain release by the urine and sweats also. And these are the excretion processes is occurring in our body. After that, there is two things. The iron is prepared in an oral form or in a parenteral form as well. Now, in oral form, it is a basically more preferred route because it is conventionally easy to take it through a oral doses form. So ferrous salt preferred. It is a cheap and high iron content, and it has a better absorption as well. So there are certain type of ferrous salt mediated iron compound like ferrous sulfate, ferrous gluconate, ferrous fumarate. There is a ferrous succinate. So these all are the ferrous compound. As well as concerned, there is a certain disadvantages also. So that in some patients we don't prefer the administration of oral iron therapy, like if there is a epigastric pain occur, there is a heartburn, there is a nausea, there is a gastric irritations, there is a blotting, there is staining of teeth, and there is a metallic taste as well. And as well as there is a constipation is more common in this iron, or if you take iron orally in that sense. So these are the this is more a type of disadvantage they have as well. In some of the conditions, like in a rheumatoid arthritis conditions, or in a condition where there is a chronic bleeding occurring, in that condition we never give a drug in a oral form. Now, as we are about to oral iron preparation, there is a ferrous sulfate, which is a 20% in hydrated form and 32% in a dried salt, and ferrous gluconate 12% elemental iron, fumarate 33% elemental iron, and carbonyl iron powder form, better gastric tolerance and less bioavailability. As far as concerned adverse effect, we are just discussed about these also. There is now we are going to study about the parenteral iron therapy. As far as concerned, there is a parenteral iron therapy needs a calculations of what the total iron requirement of the patient, for which the several formula has been advised, and there is a certain formula which is the iron requirement in a mg, and equals to 4.4 into body weight kg, and HB deficit, which is a hemoglobin deficit in a percentage gram per deciliter. In that sense, we need to formulate the calculation of this formula. And there is a Parental iron, there is a conditions in which we give uh, intolerance conditions, in which there is an intolerance condition that the patient is not taking the oral drug because they are intolerant against that drug. In a malabsorption, they don't absorb that drug. In an inflammatory bowel disease, they don't absorb the oral iron. In a non-compliance conditions, so that it not compliances to the patient. In a severe deficiency, like there is a chronic kidney disease if the patient have, so in that condition we always prefer the parental dosage form. And along with, there is a erythropoietin deficiency. If there is a erythropoietin deficiency, which is a EPO hormone released by the peritubular cell, if there is deficiency also occur, they don't feel then we always prefer the parental dosage form. Now, as far as concerned about the parental iron preparation, there is a certain preparation which is iron dextran, iron sorbitol citric acid, ferrous sucrose, and ferric carboxy maltose. So as far as concerned about, I just want to tell about the iron dextran, that it is the only parental drug of parental iron drug, which can be taken through the IM route as well, and through the IV route as well. So there's a they but as we all know that there are the certain side effect, but there is a more common side effect which occur in all these types of parental iron preparation drugs as well. And it is mostly it is used in two things. There is a iron deficiency anemia if occur, and if there is a megoblastic anemia in which the bone marrow depletions occur, so that there is a not forming of new blood cells and in a proper amount. So as far as therapeutic uses, these are the oral iron prepared in that case. Uh, we called as a prophylaxis we use in a pregnancy, infancy. Infancy is a condition in which there is the infant child which don't have that much amount of blood, so that we give the iron in that case. There is a chronic illness, if there is a chronic bleeding occurs in our body, in that case we can give. And in a menorrhagia, in which there is a excessive blood loss through the menstruation, in that condition we give iron. In acute blood loss also. As far as concerned about the megoblastic anemia, along with the vitamin B12 and folic acid depend on iron status as well. So the megoblastic anemia depend on the on all these three substances as well. As far as concerned, there is a maturation factors. There is a maturation factor which is vitamin B12, and there is a folic acid which we call it a vitamin B9 also. As far as concerned about the vitamin B12, these are synthesized by the microorganism. As we all know that there is a streptomycin, streptomycin griseus, which we also know about in these things in aminoglycosides antibiotics. So these are the things which we need to understand in that way. It is a dietary sources. We can take it by the liver, kidney, sea fish, or egg yolk, or meat, and through the vegetables, which is the fruits, lack cobalamin unless contaminated by the microorganism. So there is need to be a contamination by the microorganism, and the specific microorganism which is the Streptomyces griseus in that way. And after that there is a daily 1 to 3 microgram is needed, and in a pregnancy and lactation condition there is a need to be of amount 3 to 5 microgram, and it will be present in a food as a protein conjugates is released by cooking or by the proteolysis conditions. There is a certain amount of intrinsic factors secreted by the stomach form a complex with vitamin B12 in that way. As we all know that there is attached to a specific receptor present on an intestinal mucosal cell to the ileum, so that they can easily be absorbed in our body and easily be utilized by our body, and so absorbed by the active carrier mediated transport in our body, and the transport in a blood in a combination with the beta globulin and transcobalamin also. So these are the things which we need to consider in that way. Excessive vitamin B12 is stored in liver cells as a as a 5-deoxyadenosylcobalamin. It doesn't degrade in our body. It is secreted in a bile or excreted in a urine by GFR, glomerular filtration. And vitamin B12 function, it is essential for our cell growth and replications. The rearrangement of methyl malonyl coenzyme A to succinyl coenzyme A for fatty acid synthesis in sometime in a neural tissues also. And it's also useful for conversion of homocysteine to methionine, and it is useful essentials to support the folate metabolism, which is for folate metabolism in the sense there is a folic acid, then there is a dihydrofolic acid, tetrahydrofolic acid, and so these are helping these formations also. Vitamin B12 deficiency leads to the megablastic anemia, and there is a gastric mucosal damage occur in our body also. And there is a neurological subacute combined degenerations of spinal cord, and there is a peripheral neuritis also occur, and depressed stretch reflexes there is a poor memory and mood changes, and hallucinations also occur if there is a vitamin B12 deficiency if occur in our body. There is a certain preparation which we give. There is a cyanocobalamin, which is a 35 microgram 5 ml liquid, and hydroxycobalamin, which is a 500 microgram and 1000 microgram injections, and orally and injectively it is given. As far as concerned about the methylcobalamin, that there is an active coenzyme. It is an active coenzyme for vitamin B12, and it is needed for the integrity of myelin in the nerves also, and neurological defects in diabetic, alcoholic, and peripheral neuropathy conditions. These drugs are preferred also, the methylcobalamin. And then there is a therapeutic use as well, the vitamin B12 deficiency prophylaxis, neuropathy condition, there is a psychiatric disorders, and there is a cutaneous sarcoid and tobacco amblyopia. In that condition we use methylcobalamin also. There is a folic acid. It contains 2 to 8 molecules of glutamic acid, and humans do not synthesize folic acid, and they meet the need by the leafy vegetables or by the animals through the egg, meat, or milk, and synthesized by the gut flora, but this is largely unavailable for absorption in our body. It also, I just try to add some point that it is a yellow crystal, okay, soluble in water, but when it is combined with the sodium salt, it is freely water soluble. So this is the things which we need to. And folic acid is rapidly extracted by the tissue. And it generally stored in the in a cells as a polyglutamate conjugate. And liver takes up a large part and secrete methyl THFA as a polyglutamate, and then the liver take their large part and synthesize the methyl THFA in a bile, which is mostly reabsorbed from the intestine through the enterohepatic circulations, so that they are utilized in that way. And the total body store of folate is about 5 to 10 mg, as we all know. So the daily requirement, which is in adult 0.2 mg per day. During pregnancy there is a lactation condition, 0.8 mg per day. In a total body folate in the adult 10 mg, and stored are sufficient for only 3 to 4 months. Folate is transported in a plasma. About 1/3 is loosely bound to albumin and 2/3 is unbound, and methyl tetrahydrofolate is the principal folate congeners supplied to our cells. It's rapidly extracted by tissues and stored in a proteoglycan. We just discussed about these things. And metabolic functions of folic acid, they use in conversion of homocysteine to methionine, and conversion of serine to glycine, purine synthesis, and there is a synthesis of thymidylate. There is a histidine metabolism. And as well there is a deficiencies. In the conditions of deficiency, it is also used like megablastic anemia deficiency, epithelial damages. There is a neural tube defect including the spina bifida, general debility, weight loss, and sterility condition. They also use we use folic acid in that case. And there's a oral preparation and injectable, which is 2 to 5 mg per day, or in a prophylactic it uses as a 0.5 mg per day. So these are the conditions in which these are the folic acid used: megaplastic anemia, in a nutritional deficiency, if there is an increased demand, if there is a pernicious anemia is occurring in your body, if there is a malabsorption syndrome, that there is not a proper absorption, if there is an anti-epileptic therapy is going on. In anti-epileptic therapy, the folic acid decreases. So sometimes we give the folic acid supplement so that they maintain the folic acid amount which is normal for the human being as well. Just for the erythropoietin hormone, it is secreted by the parietal blood cells of the kidney, and kidney cell releases the EPO in a response to anemia and hypoxia. If there is a condition of anemia where there is not a proper amount of RBC cells formation occurring, or in hypoxia there is not a proper amount of oxygen, there is a deficiency of oxygen, it stimulates the proliferation of colony forming cells of the erythroid series, and induces the hemoglobin formation and erythroblast maturation as well. So it releases the reticulocytes in the circulation, and it is therapeutically used in anemia for the chronic renal failure conditions. If the hemoglobin is less than 8 mg per dl, apoetoin. These are the conditions which we use. So thank you very much for giving me the chance to present in front of all of you.